All right. Good morning, everyone. Thanks for joining us for QI Power Hour. My name is Riley Woodman, and I'm with the Saskatchewan Health Quality Council. I'm joined by Jocelyn Watson, who will be speaking to you guys through this chat today as QI Power Hour. Feel free to ask her any questions if you're having any issues with the webinar today. For those of you joining us for the first time, QI Power Hour is a free monthly webinar learning series hosted by the Health Quality Council here in Saskatchewan. We bring together improvers from a variety of sectors with an interest in improving health and to learn about quality improvement related topics. So at HQC, we try to start every event off in a good way. One way we do this is by acknowledging the land we're on. So the Health Quality Council is situated on Treaty 6 territory and in the traditional land of the Dakota, Lakota, and Nakota, and is the homeland of the Métis. We pay respect to the treaties that were made on this land and acknowledge the harms and mistakes of the past. We're committed to moving forward in partnership with Indigenous nations in the spirit of reconciliation and collaboration. And feel free to put in the chat or acknowledge the land that you're joining us from in the chat. All of our sessions, including this one, are recorded, and they're available on our website following the event. Feel free to share these recordings with colleagues who are unable to join us today, and check out ones that you might have missed. While you're on our website, we invite you to sign up for our distribution list to ensure you receive regular invites to all of our upcoming QI Power Hour sessions. Over the last year and a bit, we've been excited to see the continued growth of QI Power Hour throughout our home province of Saskatchewan. Across Canada, and worldwide. Part of what makes QI Power Hour fun is engagement and participation. So we'd like you guys to all join us and in the discussion in the chat. It's on the bottom right-hand side. Just make sure that when you're sending out messages, it's to everyone. Sometimes it can be just to the panelists or just to the host. So make sure it's to everyone so everyone can see it. So right now, if you haven't already, please try out the chat and tell us where you're from. Looks like Southern Saskatchewan, Yorkton, Kindersley, Regina, excellent. Battleford, good. There's 48 people on. Let's see some more. Excellent, thank you. You can join the conversation on Twitter with our handles, and you can join with HEC_ES_Canada and Jess_CC. So without further ado, I will share the ball with our presenters today, and they can get started. Thank you.
Thank you, Riley, and to the Saskatchewan Health Quality Council for inviting us here today to speak about safely reintegrating caregivers as essential care partners. We're pleased to be sharing the work of the newly launched Health Excellence Canada, an amalgamated organization that brings together Canadian Foundation for Healthcare Improvement and the Canadian Patient Safety Institute. We work with diverse partners to shape the future of quality and safety to build a better healthcare system. My name is Jessie Checkley. I'm the Senior Improvement Lead with the Patient Partnership and Engagement team at HEC. And I would like to start by acknowledging that I'm coming to you from my home office, where I have the privilege to live, work, and play along the banks of the beautiful Ottawa River. In particular, as I'm from Ottawa. I'm on the land that has been inhabited by Indigenous peoples since the beginning, and that this is the traditional and unceded territory of the Algonquin Nation. I recognize and deeply appreciate their connection to this place. With me today is Carol Fancott, the Director for Patient Partnerships and Engagement at HEC. Let's see, slides here, sorry about that. In today's session, you'll gain insights into Essential Together, the program, its goals and approach, understand how Essential Together is responding to the priorities and needs of patients, families, and caregivers during the pandemic and beyond, learn more about the evidence that supports Essential Together and the development of our policy guidance, and a little bit about how we'll know we've been successful or what success looks like for Essential Together. Maybe I'll ask Jocelyn or Riley just to pull back the poll results so we can see who we've got in our audience and sort of what roles you have, as well as the comments about whether essential care partners are included in your facilities at this point, or whether they're being restricted. Maybe I've thrown a wrench in the works. There we go. So we've got some health system leaders, some healthcare providers, some patients, residents, families, caregivers. Welcome to you. No policymakers, but some researchers as well. And it looks like many of you are welcoming essential care partners into your organizations or facilities at this time. And so, you know, that's always a good sign that we're moving in a good direction. So Carol, over to you.
Thanks so much, Jessie. And yes, certainly thank you for this invitation to be able to speak about this issue of family presence and essential care partners, and one that's certainly been highlighted throughout this time of pandemic. So what is Essential Together? So next slide, please. And Essential Together is a program that has been developed during this time of pandemic in order to support the safe reintegration of essential care partners into health and care facilities. And so the three main audiences for this program are policymakers, those who implement policy, and there has been a huge focus on health leaders and administrators and organizations to ensure that they are able to implement the policy guidance. And then, of course, those that are impacted by policy. And currently, we do have a patient and caregiver group that is working with us to develop what is needed from their perspective to support the safe reintegration of essential care partners. Next slide, please. So what's been interesting to reflect on is how family presence policies and practices actually were on the rise across Canada prior to the pandemic. Many of you may have known the legacy organization of CFHI, as we had supported family presence through our Better Together programming starting in 2015. And at that time, Saskatchewan was really taking the lead in family presence with its provincial rollout. And we learned a lot from you during that time and in the work that we were doing with Better Together. So over the past 5 years, there was a nice steady increase from approximately 30% in 2015 to over 70% just before the pandemic hit. And to us, that was a real recognition of the value that families and caregivers were bringing to the health system and to the care of their loved ones. And that not only was it in policy, but that organizations were implementing these patient and family-centered practices. And then we all know what happened when the pandemic hit last March. The rapid closing of doors with blanket visitor restrictions everywhere. And it was really understandable at that time, where there were a lot of unknowns about COVID-19, and certainly hearing a lot about shortages of PPE and sort of this fear of what are we dealing with at the time. But what happens then when the doors closed so firmly was there was a reversion back to language of visitors, with seemingly a lack of recognition of the valuable role that essential care partners were bringing to the care of their loved ones. Now, what we've seen through waves 1 and wave 2, and they keep telling us now in Ontario we're at the beginning of wave 3, the doors are starting to slowly open back up. There's been some loosening up of the original restrictions. And I think importantly, there's been a recognition of the harms that have actually occurred as a result of these blanket restrictions. And so again, we're starting to see a bit of change of language happening from visitors to essential care partners. But what we've also seen across the country through our work of now Essential Together is that there's been inconsistent implementation of the policy guidance, and that a lot of organizations are actually struggling with the how-to ensure the safety of all that are involved within care. And so this is the work now that Essential Together picks up where Better Together had led or left off. So if we look at the next slide, I think at its core, we all know this. It's being able to differentiate between the roles, and it's recognizing the value that essential care partners bring to the system, differentiating them from visitors. And here you'll see how we have distinguished between these roles. And we also recognize we use the language of essential care partner, and that there's different language across the country that's being used, and depending on the setting. So we've heard designated caregivers, designated care partners, essential visitors as well. The key elements, though, of an essential care partner is that they're identified by patients, residents, and clients, and that they're designated by the patients, the residents, and the clients. They may be a family member, they may be a close friend or another caregiver, but the person or persons that are being deemed important by the patient, resident, and client to participate and advocate for their care. And we know essential caregivers provide support in so many ways: physical, psychological, and emotional support. And they're involved in many different kinds of activities and decision-making, care coordination, continuity of care. And importantly, for those patients or residents or clients that are unable to communicate or advocate for themselves, they help to provide that voice. And so if we look at the next slide, we know the evidence is clear. And this is what Better Together was based on. And I'm sure the work that you had rolled out in Saskatchewan a number of years ago, a lot of literature that supports the important role that caregivers and essential care partners play. And in a recent report noting up to $66.5 billion of unpaid care to patients are provided by caregivers at patients, residents, and clients in hospital, long-term care, congregate care settings, and home care. And so what we see is family presence and caregiver presence directly impacts the physical, psychological, and emotional well-being and safety of the patients and residents, reduces harm, improves outcomes and care experience. In hospitals, where we've seen family presence linked to lower readmission rates, fewer medication errors, patient falls, and improved cognitive functioning among senior patients. And similarly, the evidence in the long-term care sector shows similar kinds of results. The positive influence that family presence has on quality of life of residents, quality of care being received, improved physical and psychological well-being of residents, and their actual physical health and support with care management, reducing costs, protecting physical and cultural safety of residents, reducing rates of depression and social isolation, and reducing behavioral symptoms among residents with dementia. And family presence has also been shown to improve staff morale and communication, since the quality of information that with improved quality of information that's shared. And so what's interesting to look at now, and when we look at the next slide, is the emerging evidence that's actually been coming out since the time of pandemic. And I think there have been two key questions that have been asked. One has been around the transmission of COVID-19 in health and care settings, and in particular in relation to family presence. And what have the impacts been of the blanket restrictions that we have seen over the past year? And so we've done some work in this, and we do have an evidence brief that's widely available. And so when we look at the published evidence, both before COVID, during other outbreaks, and now during COVID, the research literature and the gray literature has been consistent, demonstrating a low risk of hospital-acquired COVID infection that is not spread due to family presence, both in hospital and long-term care settings. The caveat, of course, is when safety protocols are put in place. And so we do recognize there are internal reports, of course, from health and care facilities that may demonstrate COVID cases where there have been instances of families or caregivers and or staff that have been vectors of transmission. But what the literature is very clear on is what are the elements that are important to put in place to decrease the potential of COVID transmission, and therefore to enable the safe reintegration of essential care partners. So it's all the things that have been put in place now. We know active screening of the residents, the staffs, the care partners, ensuring that there's sufficient PPE available, proper training and adherence to the IPAC protocols that are for staff, but also for patients, residents, and the essential care partners. Physical distancing, that there's adequate staffing ratios, the ability to use technological tools for contact tracing, and that the policies or incentives are there that between facilities to ensure that particularly we're seeing people not moving from one facility to the next. So that literature is really starting to emerge and will be ongoing, I have no doubt, throughout this time of pandemic. What's also been interesting, though, to see are the impacts that the blanket visitor restrictions have had in wave 1, continuing on through wave 2, and now, as I've said, in Ontario, as they say, we're starting to enter wave 3. So what we do know from previous outbreaks like SARS that happened a couple of decades ago now, the negative and again emerging since last March, the negative outcomes for patients, families, and caregivers, including social isolation, emotional distress, communication difficulties, when there have been these blanket visitor restrictions in place, and particularly those that are medically vulnerable. So, for example, in intensive care or some more elderly residents and patients, more likely to experience medical error, costly non-essential care, emotional harm, social isolation, inconsistencies in care. And specific to long-term care and other congregate settings, higher rates of loneliness and depression, mood and behavioral issues, feelings of helplessness, guilt and confusion, and feelings of abandonment because they don't understand why their loved ones aren't able to come in. And what we also know is families and caregivers are also suffering from increased levels of stress and anxiety, and staff too are struggling to fill the role that they feel essential care partners were playing. They're feeling increases in burnout and moral distress, and also suffering from gaps of information because the essential care partner isn't there. And all of this then points to the need for us to take a much more balanced approach in understanding the multiple risks that exist during this time of pandemic and trying to balance out those risks of transmission with person-centered policies and practices. And so how is it that we can safely reintegrate essential care partners? So if we get to the next slide. So that is our question, and that is really where Essential Together comes into play. And so I'm just going to go over in the next slide sort of some of the principles that that are foundational to Essential Together, and also to the policy guidance that we were able to co-develop that Jessie will be sharing with you. And so in this last summer, we had embarked on a policy lab approach that brought together a broad range of stakeholders, policymakers, those that implement policy, those that are impacted by policy. And based on the work that we did together, really came to not only the policy guidance, but an understanding of, at its core, as we've talked about, recognizing the valuable role that essential care partners play, being able to differentiate the role of an essential care partner from that of a visitor, and to use that language consistently. And importantly, engage with patients, residents, families, caregivers in any of the changes being made. And we've seen this across the country in looking at places where essential care partners have been embedded or where there's been less disruption, with essential care partners being able to be reintegrated into care. And in those organizations, that element of engagement has always been a key factor of being able to reach out very quickly in those early days of pandemic, being able to work together with patients, residents, families, caregivers, and being able to shift their practices accordingly, but to be able to find that balance. So I'm going to hand it over to Jessie now, who's going to talk much more about the policy guidance itself and the program of Essential Together. Thanks.
Thanks, Carol. So as we look at this next slide, really thinking about how we brought together these three key audiences that Carol mentioned previously: our policy makers, our policy implementers, and those who are impacted by the policies that are put in place. And so what we did was, as Carol mentioned, we brought together a group of folks in early July through September as part of a policy lab process. And we asked them to think about what safe reintegration of essential care partners could look like and would look like, given COVID and the situations that we were in. And what they very quickly identified was that there were three areas that were areas of focus when it came to caregiving. So the identification of the essential care partner, the entry into facility, and then the caregiving itself. And they felt really strongly that if you can't get into the facility, then you won't be able to provide that caregiving. And so they really wanted us to focus on that identification of the essential care partner and the entry into facility. And I realize this map is very small, so I've included a link in the chat box for folks. But really about those elements that would be key in order to be able to have identification of the essential care partner and entry into facility. In addition to that, they brought these pieces together and they really thought about what elements of policy guidance might look like and shared with us very openly about that. So we developed a policy guidance for reintegration of caregivers as essential care partners. Again, the link is in the chat box, and I'm sure many of you have seen it. And it really delves into three guiding principles that Carol talked about, and then the 7 elements of policy guidance that fall under the heading of identification and preparation of essential care partners, and then entry into facility. And so the crux of this is that there needed to be a mutual set of expectations of responsibilities between the caregiver, the patients, caregivers, residents, as well as the staff, in order to be able to bring essential care partners and caregivers into the health and care facilities. That there needed to be a pre-entry preparation for essential care partners. So essential care partner education about things like PPE and infection prevention and control procedures and policies. They needed to establish staff education so that staff could understand the roles of a caregiver or essential care partner, and understood that there were protocols for the entry of essential care partners, like the training that they would do or the education that they would do, so that they could feel comfortable welcoming essential care partners back into the organizations. And then that each of these organizations really needed to establish a rapid appeals process, that there would be situations where it would not make sense to have an essential care partner come in, but that there needed to be an appeals process that was transparent and available, and most importantly, that was rapid and didn't take months and months of time, because we were in a crisis, but also because of the stress and the strain that both patients, staff, and essential care partners are feeling about these lockdowns and closures. And then when we think about entry into facility, there needed to be a clearly established and transparent communicated screening process for essential care partners, and it would be very similar to the screening process that you would see for staff. And in many organizations that we've heard from, actually they're exactly the same. That the organization, the health or care organization, can establish a caregiver ID program for essential care partners so that it was easy for staff within the facilities to identify who an essential care partner was versus a visitor or someone else. And that would ease the entry into facility for those essential care partners who had done all of this training and had been prepared to come into the facility safely. And then, of course, ensuring that essential care partners were informed of existing and then updated IPAC protocols, because this remains a moving situation dependent on the region you're in, sort of the levels of infection that are in the communities, and then what the different systems are within your provinces, within the provinces and territories, for moving to sort of a red zone or a gray zone. And in each province and territory has its own type of approach to that, but making sure that all of that information was communicated and updated on a routine basis. So as we began to sort of do a bunch of this work, we were moving into November, where we launched the policy guidance itself. In December, we actually launched the Essential Together program and our evidence brief, which we shared with you in the chat box. And then we began program rollout in early January. We brought together our Essential Together patient caregiver advisory group that Carol spoke about, which is a group of patients and caregivers who have come together and are supporting us in thinking about what the needs are within that caregiver audience in order to be able to support the safe re-entry. And then we recently published in Healthcare Quarterly about our work with Essential Together and the evidence that Carol spoke about. And as we move through 21 and 22, we'll continue to roll out programming and ongoing dissemination like today's opportunity to make sure that people are aware of what's available and how we're supporting. So if we think about Essential Together itself, it's an open access program. So everything we have is available on our website, and the intention is to support the implementation of the policy guidance and to welcome back essential care partners in all health and care settings. And it really is that simple. Our goal is to support where needed those who are interested in implementing this policy guidance and welcoming and supporting essential care partners to come back in. We put out a call to action and for each of our 3 audiences, there are actually specific goals that we have. So for those who make policy, it's really around a change in language from visitors to essential care partners, and that understanding of the value and the role that essential care partners play. For those who implement policy, you can see our call to action that as leaders and providers and staff within health and care facilities, they value and support the role of ECPs within their organization. They support patients, residents, and clients to identify their essential care partners, and they're committed to welcoming back and supporting essential care partners to safely participate as part of the care team. And for those who are impacted by policy, we've talked about this caregiver audience advisory group that we brought together, and we're really working to co-develop what we might provide, what we might support the development of. And we're not quite there yet. We're having discussions about what that might look like, but this group has not made a decision about what is needed. And so once we get closer to that, we'll definitely be rolling those pieces out. I think I mentioned open access, so all of our materials are available on our website. We have sort of a bit of a stepwise approach to this. So as I mentioned, the step 1 is the call to action. Step 2 is a bit of a self-assessment tool. So organizations can download the tool or fill it out online, and it's basically looking at the different foundational guiding principles, as well as the 7 elements of policy guidance, to support organizations or health care facilities to understand where they are. Have they implemented or achieved what they're hoping to related to rapid appeals process or mutual expectations? or caregiver ID. And if there's work to be done, then, what resources do we have that are available? And those self-directed learning bundles are available on our website. And so it's a set of curated resources and tools, as well as of leading organizations, videos of leading organizations that are doing work in these areas, as well as some peer learning, which we're doing through a series of huddles, and I'll mention those on our next slide. But we've set up a series of 7 or 8 huddles where we bring in an organization who can speak to one or two of the elements of the policy guidance and what that looks like for them. And then we have an open dialogue where organizations or participants can share where they are. They can ask questions. They can share what they've been doing within their organizations. And of course, this is across pan-Canadian activities. So there's lots of opportunities for learning and cross settings. So, we welcome folks from both hospitals, primary care, outpatient, congregate care, as well as long-term care. We have close ties with our long-term care program, long-term care plus programming. Because as Carol mentioned, a lot of the things that are relevant to long-term care are also relevant to these other care settings. And we're seeing that the policy guidance is relevant as all of these settings move forward in thinking about implementation. We also offer one-on-one coaching. So through registration, teams or organizations can receive one-on-one coaching about any of the areas that they're interested in pursuing or they might need some support with. We have some upcoming huddles, as I mentioned. So our next one is on April 8th, and it's entitled Mrs. Jones, Who Are Your Essential Care Partners? And then right through to the end of June, we have a series of, and these 45-minute sessions. So they're pretty quick. Not a lot of talking, but a lot of sharing back and forth. We ran our first one yesterday. So, and of course, the archives are available on our website or will be shortly, so folks can have a look. Carol, I think this is back to you now.
Thanks, Jessie, for that great overview. And I think one of the key points, the whole essence of Essential Together has really been that we wanted to be able to have essential care partners be welcomed back where those very abrupt restrictions had been put in place. So it was really important for us to make sure that everything we were doing was open access. So it sort of follows a slightly different model than what we had done in the past in terms of the programming. And so in terms of when we think about what are the elements of success, the implementation of this policy guidance across health and care sectors is at the top of the list. That essential care partners are being safely welcomed back into the facilities to be able to support the care of their loved ones. Because we've taken this open access approach, we are just monitoring how often are the bundles and the learning resources, coaching and peer learning being accessed both through our website, but then also through the other offerings that we have. And as Jessie just noted, the learning huddles that we just started hosting yesterday, actually. We, through this whole time, have been monitoring what are the policy directives that are being put out across the provinces and territories. And so we actually just did an update of those, where we can see how has the language shifted, what are provinces now saying, how has that changed from the early days. And again, around the language. And then importantly to us is the engagement of patients, residents, families, caregivers, not only in the development and implementation of what's happening, but also in our work, and how we are bringing them into our work to really guide the pieces that we've just talked about now. So on to the next slide, Jessie. So you can contact us through the Essential Together email address. And as we said, everything is openly available on our website. And if you take a look, and we will show you on the next slide, from the very start of this pandemic, this issue of family presence, of being able to safely reintegrate essential care partners really came based on the needs of patients, families, residents, clients, caregivers, and we had generated a lot of pan-Canadian discussions in the early days when the pandemic first hit. A lot of them focused on this issue of family and caregiver presence. Through that, we've been harnessing and generating the evidence base. So as I said, tracking the policies again, which are available through our website of what's happening across Canada and the policy directives that have come out provincially and in the territories, but also the evidence brief, which was developed sort of back in the fall, and we'll be doing another update. I will say there's a lot of evidence that's being generated through our long-term care plus program as well, and the implementation science teams that they have associated with this program. These are CIHR funded research teams, and many of them, they're all looking within the long-term care sector, but many of them are focused on particularly family presence and what's happened through this time of pandemic. And then lastly, as Jessie has been sharing in the chat box, onto the next slide, some of the things that we have co-developed, co-produced. There was a recommendations document that came out back in July, the policy guidance that came out later in the fall, together with the ideal journey map that Jessie had talked about, and the self-reflective tool that organizations can work through to take a look at where they're at with each of the elements of the policy guidance. So I think we will leave it there and really look forward to seeing your questions and having a bit of a discussion with you on this call. Back to you, Checkley. Okay.
Thank you very much for that. We did have a few questions come through the Q&A. So I think one question was about the links to the huddles. I believe that's on your website, and through some of the links that will be available on the PDF of this session on our website after. The first question that we have, it came through the Q&A, and is essential care partners are identified as individuals who support physical, psychological, mental, emotional. However, spiritual support is missing from this. Are providers of spiritual services considered? I can think of many cultures where spirituality is a valued part of healthcare delivery.
Yeah, I'll start, and Jessie, please feel free. You're absolutely right, and that might have been an oversight on our part. I think some of what we had pulled came from literature elsewhere. So that may have been a missing component, but thank you for raising it. And I think you're absolutely right. And there's, and I can think of examples as well. I think we should be calling that out separately, you know, some of which may be related to other aspects of health, but I think you're absolutely right. So thank you for that, raising that point.
Okay. Just as a follow-up, it says, forgive me in advance if consent is spoken of in detail in the reintegration framework. I've only briefly reviewed it to date. Are there directives on consent? Oftentimes, substitute decision makers may also be the ECP or are others. How are substitute decision makers considered as part of this patient education / counseling and identification of essential care partners?
Again, maybe I'll start, Jessie. So substitute decision makers can help to identify and designate essential care partners. And I think you're right that maybe it's a dual role that they may be taking on, but they may actually also identify and designate that. So that is, I think that would be part of the consent piece. Jessie, do you have anything else to add? And I'm not sure if there's another element to that. But thank you for raising that. And I think we do have it in some of our documents and point to substitute decision makers as well.
Yeah, and I think that if I think about the example that comes to mind on yesterday's huddle, we were speaking with Grey County, the director for long-term care at Grey County in Ontario, and part of the approach that they took was going through, as they were welcoming back essential care partners was to speak with each of their residents and go through resident records to see who had been identified as an essential care partner, confirm then with the resident where possible. But in many cases, that's a substitute decision maker had been identified as part of the entry into those, the long-term care setting. And so they had that information available to them. I imagine that in other settings, that would also be the case, but not necessarily if I think about hospitals. And so I'm not sure how that works exactly, my apologies, but I think that in many cases where a substitute decision maker is involved, that sort of that information would arrive with the patient.
Thank you. We got another question that we received. As an administrator in a seniors community, not long-term care, I thank you very much for this work. I'm interested to know, what has the reception been like from both provincial and federal policymakers?
That's a great question. I think what we saw at the beginning of this pandemic, certainly there was a lot of centralized decision making that was happening, and that a lot of the policy directives were coming out from the provincial and territorial from that perspective. So what's also interesting is, as we've been going through the amalgamation to become Healthcare Excellence Canada, and what our role is in being able to support change across the system. And so we have been able to bring forward the elements of the policy guidance. We know that there is great interest in this area across all provinces and territories. And that, as I had noted before, in terms of what we consider elements of success, we have been seeing some of the language shifting from visitor to essential care partner or designated care partner in a number of jurisdictions across the country. So I think that there is absolutely recognition at the policymaker level of the importance of this issue, and that sort of clarification and differentiation that's really needed. Again, it's that balancing out. There has been a lot of fear about the transmission of this pandemic or of COVID-19, and we're really trying to strike that balance of recognizing many of the other risks inherent with the directions that are being taken. And to really amplify the need for essential care partners and the voices of patients, residents, clients, caregivers, and care partners in all of this. So definitely we are doing our best in trying to get this information out there to as many tables as we're able to, and where we're connected into. Jessie, anything else to add?
No, I would say though that certainly our president, Jennifer Zelmer, has been at several participated in several conversations where she's presented on both the long-term care plus work as well as Essential Together with the federal and provincial territorial sort of representatives, ADMs, DMs present. And so I think that it's getting there. But I think it's also a case where we're now branching out to try and tap into those existing tables. So certainly we welcome any suggestions or invitations to any of those that you might be connected with as well.
Excellent. We got two questions on language. The first one from Sherry, language can be so powerful for changing perspectives. I love the distinction of essential care partner instead of visitor. How can this language be spread more broadly? And where do you find the most uptake and the most resistance to this language? And then we had another similar question that the language is shifting, but we're seeing essential caregivers re-entering long-term care. How do places achieve this?
Mm-hmm. So I think language is powerful, and I think it's the consistency by which we use the language and the clarification at all levels of the system, right? So, right, and yesterday's huddle was really interesting, where there was a leader from a long-term care center in Ontario that really talked about staff education, about not only the role of essential care partners and the language that was used, but also, how staff are able to identify or help residents to identify or ensure that residents are identifying their essential care partners and making sure that they're clear on the distinction. So right from the start, but also the other sort of language shift or sort of constant thread related with the education with staff was essential care partners are part of the care team. That is the essence of what their role is. And so when we think about essential care partners as part of the care team, then the training protocols, the safety measures that are put in place are similar to those that staff have, who are also part of the care team. And so it was sort of building in not only the language, but the practice and that integration of that role and understanding of it. And then obviously through, at organizational leadership, it's important to be continually differentiating and using that language, and then also obviously at the policymaker. And it really, I think it stems from how it gets used in policy and the clarity of what are we calling, these visiting policies versus policies that support family presence or presence of essential care partners. And so it needs to happen sort of at all the levels. And sorry, I've now forgotten the second question, Riley. Oh.
About where do you find the most uptake, and how do you achieve this?
Yeah, so I think there was, this question around seeing it in long-term care in particular, or how do places achieve this? So I think the policy guidance that we have put out is a starting point in terms of what are those clear policy pieces that need to be put into action, and how can we safely do that? And there are a number of organizations absolutely that have done it. And I think especially in the long-term care sector, our partners within Healthcare Excellence Canada, who are leading the Long-Term Care Plus program, one of the promising practices that they're also promoting is around presence of family. And so we've been working closely with them. And as I said in the huddle yesterday, for example, it was a great example of a long-term care center that has implemented those elements of the policy guidance, and describing exactly how did they do it. And yes, in yesterday's example was great because she talked a lot about the engagement, not only of the residents and the caregivers in the changing of policy and practice, but also staff. And that was very, very important because there was a lot of fear of staff about having more people in the facility and what does that mean related to transmission of COVID. So, that engagement process as well was really, really important in order to be able to change the practices and how the practices were being implemented.
I'd also add that, this organization that we're talking about started this work last year. And, the director will let you know when you speak with her that she didn't know what she didn't know. She knew that residents were not thriving. She knew that, she wanted to bring essential care partners back in, but she really went about reaching out to other organizations and learning from them. So she didn't have to start from scratch. She joined as many of the different sort of opportunities, collaboratives, et cetera, that she could, that were available, to try and learn more from others. And she certainly spent a lot of time reaching out, and has very graciously made herself available to folks who are interested in doing this work, and sort of, because nobody wants to have to recreate the wheel. And so, she looked at other areas actually of care within Ontario, looked at what they were doing, then adapted that for her context and what made sense in her region and her purview. And one of the things that always resonates with me when she speaks about this work is that, you know, she looked at how they were going to manage bringing in essential care partners. And because she had the sort of the grounding in, they are part of the care team, the testing that's done for essential care partners is the same as staff. The education that is done around IPAC and PPE is the same as the staff yet. When the vaccinations rolled out in Ontario for residents for the long-term care, residents of the long-term care homes and the staff, the essential care partners were included in that because they are considered part of the care team. And so they were able to do all of those things. Now they're in a smaller region within Ontario, but I think it's possible. It's certainly possible with a bit of imagination and sort of some of those supports of others who have done this as well.
Excellent. We have a few more questions. There are some good comments being made in the chat as well. The one question here about metrics. You mentioned a metric being changed to essential care partners. Are there other metrics that are encouraged to be evaluated for successful implementation of this reintegration?
So I think one of the ones for us. So the sort of elements of success that I was speaking about previously was partly in relation to Essential Together, obviously, but I think the broader picture of that is, you know, the goal is about the safe reintegration. So I think one of the key metrics that we'll be looking at, we have, because of the work that we had done previously in Better Together, we had some data that demonstrated where family presence policies had been in place, particularly in hospitals across Canada through a 5-year period. So now we're able to track that moving forward of what is it looking like now that we're in COVID or even post-COVID times, of what is family presence looking like across the country. So those are ones that we're going to be continuing to do follow-up on. And I think that is really the goal of the programming. But in the longer term, you know, family presence is a very concrete way that represents patient and family-centered and partnered care principles in action. And so I think it was devastating for many of us that have been in this field for a long time, and certainly, obviously, for essential care partners, for patients, residents, clients. You know, those restrictions that came down really felt like what many of us have been working towards and thought was embedded within the system of patient or person-centered care. It felt like it had disappeared so quickly because of that change of language back to visitors, because it felt like there wasn't a real recognition of the role and the importance and seeing them as part of the care team. And I think that's why it struck Jessie and I both so much yesterday in listening to this senior leader talk about, but the essential care partner is part of the care team. And to me, that is part of the essence of bringing in those person-centered, you know, patient and family-centered principles into practice. And when they disappeared so quickly in those early days, it sort of made us realize that fragility of really the philosophies of care that were embedded within the system or not at the time. So, you know, we'll be tracking that, and we'll be doing follow-up studies to take a look at where have organizations opened up, what is that looking like, and because we have the data sort of pre-pandemic as well, we can sort of start tracking it.
Excellent. There's just been a couple comments that I just wanted to read because the recording doesn't have the chat, but there is one that I think it's very important to introduce this type of lecture or presentation to most care homes for proper understanding. There's been some comments about using COVID, using this opportunity using COVID as an opportunity, because we know there's going to be many more lockdowns. There's going to be lockdowns in the future, and using this opportunity to implement and practice the guidelines, which hopefully become standards that are required, reviewed, and assessed. I saw another question, sorry. And are these metrics, are you hoping that these metrics become part of the accreditation process and assessments?
Yeah, so thank you for that question. I think that's a great point. As we were developing out Essential Together, certainly we've been having conversations with colleagues at Accreditation Canada. So it's a good flag to be looping back and keeping them in this loop. So because that it's another organization, obviously, that takes on accreditation, but just so that you know, there have been conversations in the past, certainly about our work and support for it. And we know that accreditation, they have many person-centered principles and practices that are embedded. So this will be an ongoing conversation. But you're right, I think as many levers as possible that we can be putting in to ensure how are we embedding these more fully. Because you're right, there will be sadly other outbreaks, whether it's COVID or something else in the future. But even beyond that, we talk about, we're intensely in this space now because of COVID. We were working in this area prior to COVID already. And that, our intent certainly is, regardless of a pandemic or not, it comes down to the essence of those person-centered policies and practices, and how do we more firmly embed them in the system so that when there are times of crises, they don't disappear, that they will be considered, that there will be a more balanced approach, that those engagement practices will kick in, that engagement won't fall by the wayside, but rather, people will be doubling down on, we know change is going to happen because of this crisis we're in, but that engagement with those that are going to be most impacted by the change will occur, so that the change is something that ensures that balanced approach moving forward.
Excellent. Oh, sorry, Jessie, did you want to?
No, I'm fine, thanks.
We just have one last question, and it's kind of specific. But are essential care partners going to be included in education and isolation and reverse isolation techniques, as well as the importance of changing shoes and clothing on entry and exit of the facility?
So what we have found, so the policy guidance that we provide speaks of safety protocols, but there's also an understanding that depending on the context, depending on community transmission at the time, different organizations obviously have different safety protocols that they are putting in place. So it would be very dependent on the amount, like the type of safety training that an essential care partner would go through, dependent on the unit, dependent on the organization. And if that is deemed an important element of the safety protocol, then they would put that in place. There is, and if you look on our website, there's some broader IPAC training materials that are available that many organizations are using that provide that sort of broader lens on infection and prevention control practices. And then when it's organization specific, that needs to come from the organization.
I think also that, even within a single organization, there may be areas of the hospital areas of the facility where there are more intense expectations around infection prevention and control procedures, and other parts where, a mask and a gown and a little bit of training is appropriate. And so, as Carol said, the facilities themselves will set that, but that's part of the policy guidance and thinking about what are the updated, expectations, both of training and of knowledge that are shared with essential care partners, and that essential care partners must follow as things are constantly moving. And we know with this type of, after a year, we know that with the pandemic, often things are shifting, week to week, sometimes day to day, sometimes by hours. And so that's why that open communication and that those routine updates are so important.
Excellent. Well, with that, thank you very much, Carol and Jessie, for giving us this presentation today. Thank you to everyone who joined and participated in the chat and watched, and thank you to everyone who's going to be watching this on recording later. So when you're a QI Power Hour speaker, you get some coveted QI Power Hour socks. So Carol or Jessie will be getting either some socks or a nice HQC face mask, and I'll email you about that later. So if you want to get a nice pair of socks or a nice mask, you can email us about a potential QI Power Hour being a QI Power Hour speaker. You can go to our website to learn more about that. When you leave today, you will be prompted with a message that looks like this. In the spirit of quality improvement, we always do a survey after asking for feedback on our session. So please don't get scared off by this scary external site warning. It's safe, it's just SurveyMonkey. You can press continue, and we really appreciate the feedback. On April 23rd at 9:30 a.m., our next QI Power Hour will be joined by Dr. Volker Gertz, the Director and CEO of the Vaccine and Infectious Disease Organization that's located at the U of S, and he's going to be talking about research and development of the vaccine in a pandemic. So yeah, you can go to our website and register for that. So again, thank you very much for everyone for joining us, and a special thank you to Carol and Jessie. That was great. Thanks.
Thank you.
See you.